College of Nursing, the University of Nebraska Medical Center. We appreciate your being here today. And Dr. Calman, you're now recognized 5 minutes to give an opening statement.
Thank you. Chairman Burgess, Ranking Member Green, and distinguished members of the subcommittee, thank you for inviting me to speak to you about the THC GME, or Teaching Health Center Graduate Medical Education Program. I'm a family physician and practiced for 40 years in the South Bronx and the Lower East Side of Manhattan. I am president and CEO of the Institute for Family Health, a nonprofit network of 31 federally qualified community health centers and 3 family medicine residency programs. In 2012, we began participating in the new THC GME program to expand resident training into 2 severely underserved rural New York communities and also in Harlem and the South Bronx. As president of the American Association of Teaching Health Centers and on behalf of the 57 teaching health centers, I implore you to reauthorize the THC GME program before it expires on September 30th and to do so for a minimum of 3 years. It is a unique and critically important initiative aimed at ending the primary care physician shortage which plagues our country. The shortage of primary care in the U.S. creates an underemphasis on basic preventive health care, the delayed detection and treatment of serious disease, and the overuse of emergency care and acute hospitalization for many preventable conditions. All of this has driven our healthcare costs to unsustainable levels. 60 million Americans lack access to a primary care doctor, and by 2020, the U.S. may face a deficit of 20,000 primary care doctors. The THC programs are accountable for every dollar of funding, and they produce results. 82% of teaching health center graduates remain in primary care, compared to 23% of other graduates. Twice as many practice in underserved communities, 4 times as many in rural areas, and 16 times as many in federally qualified health centers. Congresswoman Kathy McMorris Rodgers is very familiar with the THC program in Spokane and has been a champion for increasing our health workforce in medically underserved areas, especially in rural America. We are so grateful to her for introducing bipartisan legislation to reauthorize the program sustainably for 3 years and to fund expansion to help satisfy the pent-up demand throughout the country for new teaching health centers. We appreciate that Congresswoman Tsongas and 67 other members of Congress co-sponsored this legislation, including Congressman Jeff Denham, who not only co-sponsored it, but also introduced his own legislation that would appropriate even more funds for expansion. Traditional graduate medical education occurs almost exclusively within hospitals, but primary care takes place in the community, in doctors' offices, and in community health centers. To get more doctors in primary care, especially in the areas most in need, teaching health centers move training into the community where residents and their faculty do over 600,000 patient visits each year. Primary care providers are the first place a person goes to find out if their cough is from common cold or from pneumonia, whether their headache is from stress, an impending stroke, or a brain tumor. They learn to identify and treat anxiety and depression, and they learn to treat pain while minimizing a patient's risk of developing opioid dependence. Primary care saves lives and saves money, and the Teaching Health Center Graduate Medical Education Program helps solve our primary care crisis. However, it's 2 weeks away from extinction. We need it reauthorized now and at the level recommended in the HRSA-funded study published last year of $157,000 per resident per year. We need a 3-year authorization at $116.5 million per year so that centers will not terminate their training programs and continue recruiting new residents. When our center extends an offer to a resident, we make a commitment to them for 3 years. A 2-year federal funding commitment is insufficient to stabilize our programs. In addition, we have had grossly inadequate funding for the past 2 years, as low as $95,000 per resident. As a result, some centers were forced to stop recruiting. In my program at the Institute, the decrease in funding from the initial level of $150,000 per resident per year created a loss of $2 million a year and forced us to reduce our Harlem residency from 36 to 18 doctors. The McMorris-Rodgers-Tsongas legislation funds $157,000 in training costs per resident for all 732 current residents and additional funds for up to 10 new programs. This will add another 120 primary care residents. In closing, I want to stress that the health of all Americans requires that the other programs that you'll hear about today are also funded timely and adequately. The National Health Service Corps, which provides doctors who serve in our nation's community health centers, the community health centers themselves that provide care to 24 million Americans, and Title VII and Title VIII, which supports training in the critical disciplines of medicine, nursing, dentistry, and others. Thank you for giving me the opportunity to testify this morning.
I like the approach that the Teaching Health Centers program helps local providers like community health centers grow their own workforce. Can you explain how this residency program boosts staff ranks at rural and community health centers over the long term?
I'm sorry, could you repeat the last sentence? It didn't.
Oh, could you explain how this residency program boosts the staff ranks at rural and community health centers over the long term?
Sure. The program is really geared towards taking medical students and bringing them into programs in rural and underserved areas. And when they train in those areas, they have a much higher probability of staying in those areas. So if you think about bringing people who might normally train in a regular big hospital in the city, but now moving them out into the community for their 3 years, they develop relationships in those communities. It's a different style of practice to practice in a small rural community. You learn different skills. You learn to be more self-reliant. As Dr. Billings explained, you get a sense of self-reliance that allows you to go out into places where there are not a lot of doctors and not a lot of specialists. And so, we're creating that pipeline for people so that you can go into these communities and serve.
Okay, thank you. Dr. Knable.
But adding a provision in the 21st Century Cures Act that designated pediatric mental health professionals to be eligible. A little bit of a fight to do that, but I prevailed so that they could participate in the public health service course. So I appreciate your sharing that with me. Is the program's current per resident funding level appropriate? Who can answer that? Mm-hmm.
Yeah, I guess that's for me. So the Teaching Health Center Graduate Medical Education Program was originally funded, as you said, at a level of $150,000 per resident per year. So that was based on a historical analysis of what it costs to train a resident. What actually ended up happening when it was reauthorized was people forgot to take account of the fact that the number of programs had been growing, and also the programs had been ramping up from just having first-year residents to having first, second, and third-year residents. As a result of that, the funding was reduced to $95,000 per resident per year, which is really only two-thirds of the costs, two-thirds of the dollars that are needed to support just the resident salaries and the faculty salaries in those programs. That number's now up to $116,000, and so programs should be happy that they got a little bit more money, but not happy about how it happened. Mm-hmm. How it happened was programs dropped out at the lower reimbursement level. They couldn't support the residents. They couldn't support the faculty. And so we lost a lot of training slots through this new program. And, as you said, when you think about a program starting, the remarkable thing was there are 57 new programs that developed across the country in the short period of time that this program's been in existence. All of them geared towards one thing: training doctors for underserved rural and urban communities. Right. 57 new programs that just literally grew out of nowhere, got accredited, went through the enormous accreditation process, and all expecting that the funding would be there to continue. And so we're really in crisis now and about to lose more programs. 2 more programs closed just at the beginning of this academic year. A critical program in inner city Detroit and a program in rural Oklahoma. Both lost, programs that had been started up through the initial funding but couldn't sustain themselves on the inadequate funding that we currently get.
Well, we obviously need to reauthorize. That is absolutely essential. It's critical. But we can't be self-congratulatory by simply doing that. I think that you have all made the case, the nurses, everything that you're doing at the county hospital, that the funding has to be appropriate for it.
Totally.
No one sends their kids off to college and said, well, I'm going to pay for room and board, but I'm not paying for your tuition. I mean, what kind of a deal is that? So we have work to do, and I hope the outcome will be worthy of the work that you do and what
Thank
you
you
have
very
chosen
much.
to do with your lives. You really are great Americans. Thank you.
Thank
God
you.
bless you. Thank you.
Gentlelady's time has expired. Chair recognizes the gentlelady from Washington, Ms. McGuinness-Rogers. 5 minutes for questions, please.
Thank you, and I agree. I so admire the work that you do, and I appreciate your commitment moving forward. Just a few questions, Dr. Calman. Wanted you to address, and I know this has probably somewhat been addressed in other questions, but how would your health center be able to make up for the loss in funding for each residency slot if the THC GME program is allowed to expire on September 30th? If this is even financially possible, how would shifting these dollars impact core primary care services for your patients?
So it's not really possible. I mean, the community health centers that are the sponsors of the vast majority of the teaching health center slots really don't have excess income. And so, you know, what we've really seen is a loss of program slots. You really can't sustain the program on inadequate funding. We lost 170 positions since the start of this program just a few years ago with the reduction in the funding that came with the last inadequate reauthorization. These are 170 doctors that would have been out practicing in needy communities that can't be replaced at this point. And so we will continue to lose slots. We will continue to see programs close, like the two that I just talked about that have just closed, because you can't sustain the funding for these programs. These are real costs. The difference between this program and regular graduate medical education is that we are accountable for every dollar. Every dollar goes to either a resident salary, a faculty member's salary, or other program costs that we have to account for in every allocation.
So the legislation, H.R. 3394, provides funding for 3 years at roughly $157,000 per resident per year. Would you address why this level is so important to the teaching health centers like mine in Spokane and across the country?
Sure. So in the original authorization of this program, there was a demand that the secretary get an outside entity to do a study of the actual costs of residency training. And that study revealed that the actual costs were $157,000 per resident per year on average. So if the funding isn't reauthorized at that level, we are basically putting the program in deficit to start. And you just, you can't really do that. And I think we really have to see this as an investment. This is an investment because in every study of primary care, the more primary care providers you have in a community, the lower the healthcare costs in that community. The more specialists you have in a community, the higher the healthcare costs in that community. So this is an investment. We're investing in the training of primary care people to reduce healthcare costs and to be able to provide better care in communities that have no doctors at this point, no or few doctors.
So building on that just a little bit, would you agree that the THC GME program is accomplishing the objectives Congress laid out when it was established? And how does your association know that this program is actually producing physicians that go on to practice in primary care?
So we track outcomes. This is an outcome-based program like all grant programs. And so we can tell you that the percentage of regular graduates that go into primary care is normally 23%. 82% of the teaching health center graduates stay in primary care. There are twice as many that stay in underserved areas. There are 4 times as many that stay in rural areas, and 18 times as many graduates of teaching health center programs go into community health centers, federally qualified community health centers, than come out of the normal GME program. So we are responsible for outcomes. And in fact, in your current legislation, there's a whole new set of criteria and outcome measures that must be reported from the programs around the country.
Thank you, Dr. Calman. I have several letters of support in favor of H.R. 3394 that I would like to submit for the record. And with that, I yield back.
Without objection, so ordered. Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from New York. 5 minutes for questions, please.
Thank you very much, and I'd like to throw my lot in with Congresswoman McMorris-Rogers. I'm glad, Dr. Calman, that you explained about the September 30th deadline, and I want to particularly welcome you, since
Thank you.
I'm a fellow New Yorker. You do good work in my home city, and we thank you, and you're a very good institution for what it does. HR 3394, sponsored by Congresswoman McMorris Rogers, would provide a 3-year extension for the Teaching Health Center program. I wanted to focus on that. I've heard from advocates that an extension of at least 3 years is critical. So, Dr. Calman, could you explain why the program would benefit from a longer-term extension?
Sure. You know, when we bring a new resident into our program, we commit to them for the full length of their primary care training, which is 3 years. So the residents know this, and we get questions from applicants. The average program that runs a teaching health center gets over 1,000 applications for a handful of positions. The residents that we want are the best.
It's like the House of Representatives.
So
And
the,
don't
res-
pay as
the,
much.
the residents we want are obviously the best and most committed people. They come in and they ask, how do I know you're going to be able to complete my training? How do you know that you're going to have the funds to complete the training? Because the teaching health center funds, expire in very short term. And so it's based on that commitment. That commitment is built into the accreditation that we all had to get, because the ACGME, the accrediting entity, says that once we take a resident, we are responsible for the completion of their training in our program. And so, we need long-term funding in order to provide that security to the program applicants and also to the programs.
Well, thank you. And HR 3394 also contains additional funding for an expansion of the program. So let me ask you again, Dr. Calman, is there currently demand for new teaching health centers and new residency slots in the program?
So there's enormous demand. As I said, we get, our own program gets over 1,500 applications for 8 positions. So we know there's demand for more residency training slots. We also know that there's demand for new programs, because as president of the American Association of Teaching Health Centers, I get these inquiries all of the time. We get calls from community health centers saying they really are interested in building this sort of pipeline track within their programs by starting a training program, because maybe that area of their state has had a problem recruiting or a problem maintaining an adequate workforce. And so all over the country, there are places that are contemplating starting new training programs. And the only thing standing between this and a much larger solution to our nation's primary care crisis is the level of funding and the number of programs we can fund, because every program trains exclusively in primary care, and according to the new legislation that's proposed, would be training people in underserved communities.
Thank you. I hope we can pass this bipartisan, bicameral bill as soon as possible, so that teaching health centers can continue to provide much-needed care to our communities. I want to
Chair, thanks, gentlemen. Gentleman does yield back and recognize myself for questions. And Dr. Calman, let me just, as a point of clarification, but for someone who is watching this hearing today, I don't want them to get the mistaken impression that you are paying your residents $157,000 a year. I recall.
We wouldn't have any problem recruiting.
That's exactly right. When I was a resident at Parkland Hospital my first year, I think it was under 10,000,
Right.
well under 10,000 that we earned. But that is the total cost of providing that educational experience, correct?
Exact. It pays for the resident salary, all the faculty salaries, all the administration of the program, all of the people who are doing recruiting and everything else, and substantial faculty, because these programs require faculty. Remember that in primary care, you're being trained across a broad range of areas, and so the faculty, have to be able to teach people how to do minor surgical techniques, and they have to be able to train in OBGYN, and they have to be able to train across a broad range of areas. So all of those costs are built into the 157. It's a total cost of training.
And I do want to point out that this committee early in the year passed the Improving Access to Maternity Care Act to expand the ability to place maternity healthcare providers in medically underserved areas. It actually passed on the floor of the House and is awaiting activity over in the Senate. There is a recurrent theme here that you may encounter, awaiting activity over in the Senate. I share Mr. Engel's concern that we finish up our work and both houses get the work done and get the programs approved. Let me just ask Dr. Billings and Dr. Knable,
Good break. Just came back from a break.
we shouldn't be going on a break.